Good afternoon, everyone, and welcome to this different and important session of Mhca implementation here. We have been recently designated as a CMHA center. Right? There was certain paperwork related to that, and its compliance of being a central mental health authority approved mental health establishment. We need to follow certain procedures. Some of it we have not been following very rigorously till now. We will do that, and Dr. Pinky has kindly made a nice presentation to tell us about how to go about implementation and what forms we need to be now cognizant of and to follow those processes. Right, Dr. Pinky, please.
Good afternoon, all. Today we will discuss about implementation of Mental Health Care Act 2017 at Nddtc. So, why this act came? Before these two acts were also there. Indian Lunacy Act, that was in 1912, and second was Mental Health Act, that was in 1985. After that, it came in April 2017 and came into force in May 2018. It was to provide for mental health care and services for persons with mental illness, to protect, promote, and fulfill the rights of person during the delivery of mental health care and services. So it contains 16 chapters and 126 sections. We will mainly discuss about 4 chapters, that is chapter number 2. It contains determinants of mental illness and capacity to make mental health care and treatment decisions. Third chapter, advanced directive. In 4th chapter, we will discuss about nominated representative. And in chapter 12, we will discuss about admission, treatment, and discharge. So chapter 1 mainly contains definitions. What is mental illness? As per Mental Health Care Act, that is a substantial disorder of thinking, mood, perception, orientation, and memory that grossly impairs judgment, behavior, capacity to recognize reality, or ability to meet the ordinary demands of life. Mental condition associated with abuse of alcohol and drugs, but it doesn't include mental retardation in Mhca 2017. Who is medical officer in charge as per Mhca? Any psychiatrist or medical practitioner who is in charge of the mental health establishment. What is mental health establishment? That is any health establishment including Ayurveda, Yoga, Naturopathy, Unani Siddha, and Homeopathy establishment, either wholly or partly care for patient with mental illness. Care is present there. And who is mental health professional as per Mhca? Any psychiatrist or professional registered with state authority, PG degree in Manovigyan, Manas Rog, in Nafasiyat, and in Homeopathy, Unani, and Siddha, PG degree is there, then he will be mental health professional as per Mhca. Chapter 2 will discuss about how we will determine the mental illness as per nationally or internationally accepted medical standards, that is ICD. We will decide the diagnosis. Then no person or any authority shall classify a person as a person with mental illness except for purposes directly relating to treatment of the mental illness. Past treatment or hospitalization is not sufficient to diagnose a person having his mental illness at present. Having mental illness doesn't always mean that person is of unsound mind unless it has been declared so by the competent court. In chapter 2 only we will see about capacity. It has 3 components. Earlier they have mentioned either of 3 can be present, but after an amendment in 2019, it came into force that all 3 must be present. So what is the first? Understand the information. Second is appreciate any reasonably foreseeable consequences of a decision and communicate the decision. When a person made a decision perceived by others as wrong or inappropriate shall not mean that the person doesn't have the capacity. So it was the capacity assessment guidance document that came in 2019. It omitted the odd term between 3 points, and all 3 must be present at as per that document. In chapter 3, advanced directive is there. Advanced directive is a legal document in which patient will specify the way he or she wishes to be treated or cared for mental illness, not to be treated for or cared for mental illness, and to whom he will appoint as his nominated representative. Minor cannot make advanced directive. Legal guardian shall have right to make an advanced directive in cases of minor. And advanced directive is not applicable to emergency treatment in section 94. Mental health professional is not liable for not following advanced directive if he doesn't get access to it, or if any unforeseen consequences occurs on following advanced directive, then he will not be responsible for the same. In chapter 4, nominated representative is there. If there is no NR with high support need patient, then we can consider a relative as NR, or caregiver, or person appointed by concerned board, or director department of social welfare, or his designated representative can act as NR in case if there is no NR. NR nominated representative should not be a minor in any case. If minor patient is there, then legal guardian or any other suitable person willing to act as NR if legal guardian not acting in best interest or not fit to act as NR in cases of minor. Now we will discuss about chapter 12 that is related to admission, treatment and discharge. It contains from section 89 to 85 to 99. In section 85, definition of independent patient is there, and section 86 is related to independent admission and treatment, 87 for minor, 88 for discharge of independent patient, 89 and 90 are for high support needs. If less than 30 days, then 89. If more than 30 days, then 90. 90. In 91, leave of absence. 92 is absence without leave or discharge. 93 is related to transfer to another mental health establishment, and 94 is related to emergency treatment. So in 91, as per 91 section, leave of absence, for as many days as the psychiatrist feel, we can give leave to the patient. In section 92, absence without leave or discharge shall be taken into protection by any police officer at the request of medical officer or a mental health professional in charge of the mental health institute, and shall be sent back to the mental health establishment immediately. Section 93, transfer, we can transfer the patient to another mental health establishment within the same state or in different state, but we should mention the region to patient and a nominated representative also. So this is the form we will use from now onwards in cases of absence of leave, which will be filled by nominated representative. And section 94 is related to emergency treatment. No treatment other than related to emergency should be provided in this. ECT is not allowed. Limited to 72 hours. It can be extendable to 7 days in cases of disaster or emergency declared by the appropriate government. And in section 94, we can give immediate treatment to patients of mental illness in which immediately necessary to prevent death or irreversible harm to self, harm to others, or serious damage to property by the illness. Section 95 related to prohibited procedures. 4 procedures are prohibited as per this. ECT without use of muscle relaxants and anesthesia. ECT for minors, unless permission is taken from the board and consent from the guardian. Sterilization of men and women, or chained in any manner or form whatsoever. Section 97 deals with restraints and seclusion. No solitary confinement and seclusion to be there for mentally ill patient. Physical restraints can be used only if absolutely necessary. Documentation is must in method, justification for its imposition and duration should be clear in the documentation. Not to be used as a punishment or deterrent or due to shortage of staff. Every episode of restraint should be informed to NR within 24 hours. Monthly report of all episodes of restraint should be sent to the board. So this is restraint monitoring form in which we will mention the date, time, and signature also should be there. Now we will discuss 7 case scenarios and how what forms we will apply for admission, for discharge, and we will also discuss about capacity assessment. So case 1, male patient who is 32-year-old with opioid dependence of 3-year duration with nicotine dependence is to be admitted. He willingly wants to quit heroin use and seeks admission for detoxification. Case 2 is same, but patient does not want to quit heroin use. Family members seek admission for detoxification. So what we will do in these cases, if any adult person who considers himself to have a mental illness comes to Mhca, we will confirm the diagnosis. Then we will see the capacity. If capacity is intact, then we will see the consent of the patient. If he is willing for admission, then we will admit the patient. We will apply form C under section 86. If patient is not willing for admission, but capacity is intact, then we will counsel the patient. If still denies, then respect the wishes of the patient and document reason for refusal in the file. If capacity is not intact, then we will see high support needs in section 89 in further slides. So this was in case 1. In case 2, we will counsel the patient. So this is the form for capacity assessment for every patient. We will fill now onwards. So it contains, if patient is in delirium tremens, or if we are able to see the patient is obvious lack of capacity, then we will not ask all these questions. We will directly go to the capacity part. And if patient is having some part of capacity, then we will apply all the questions and we will see patient is able to understand the information, understand the foreseeable consequences, and he is able or not able to communicate the decision. As per that, we will decide admission will be independent or with higher support needs. And this is section 86 form C that we will apply in independent patients. Now, how patient is asking for the discharge, which was who was admitted in 86. Form G is there for discharge of independent patients if a minor gets admitted and he turns 18 during the stay. So we will apply Form G only in this patient. Now, we will assess the patient before discharge. Is patient unable to understand decision and require high support or not? Possibility of bodily harm to self or to others is there or not? Inability to care for self, placing himself at risk of harm is there. If it is there, then we will admit patient under section 89, or we can discharge the patient within 24 hours, or we should complete the assessment for supported patient under section 89. If there is no harm, then we can discharge the patient and we will apply Form G in these patients. So this is the form for independent discharge, Form G. Case 3 is male patient who is 32-year-old who has cannabis dependence and cannabis-induced psychosis and nicotine dependence. Family members have brought him because he is unable to take care of himself, has not been eating for 10 days. Family members seek admission. Case 4 is the same patient, but family members have brought him because he is aggressive as he demands money for cannabis, but not aggressive otherwise. Family members seek admission to avoid disturbance at home. So if request by NR is there in case of high support need, so Form E is there for supported admission. First, it will be assessed by one psychiatrist and one mental health professional, or one psychiatrist and one medical practitioner independently on day of admission or preceding 7 days. We will see the possibility of bodily harm to self or to others, inability to care for self, placing him at risk for harm. If it is there, then we will admit the patient, or we should inform the board within 3 days in case of females, or within 7 days for other patients. If we will also see advanced directive is there or not. If it is there, then we will follow the same. If it is not there, then we will take the consent from the NR and then we will start the treatment. And we should review the capacity in every 1 week in cases of high support admissions. And we will see after reviewing the capacity in every 7 days, patient might go into independent admission in 86, or if admission exceeds then more than 30 days, then it will be admitted under section 90. So this is the admission form, Form E, and this is Form H1 that for discharge in high support need patients. Now we will discuss about minor patients. Male patient who is 16-year-old who has opioid dependence and nicotine dependence. Family members have brought him for opioid detoxification and he is willing for the same. Or male patient who is 16-year-old who has ODS and NDS. Family members have brought him for opioid detoxification, but patient is not willing for the same. So in both cases, decision of patient instead of decision of patient, NR decision will matter. NR of minor request admission, then we will apply Form D. It will be assessed by 2 psychiatrists, or 1 psychiatrist and 1 mental health professional, or 1 psychiatrist and 1 mental health professional, same independently on the day of admission or preceding 7 days. And we will see illness severity is requiring admission. Admission in best interest of minor should be there. Needs not fulfilled without admission, and no community-based alternatives is there for the minor. If it is not there, then we will not admit the patient and operative treatment will be done. If it is there, then we will admit the patient, and within 3 days, within 72 hours, we should inform the board. And we will take consent from the NR. And if admission exceed more than 30 days in cases of minor, then every 30 days we should inform to the board in cases of minor. So these are the forms under section 87 in minors, Form D and Form H. Form D for admission, Form H for discharge of the patients. Now last case, female patient who is 26-year-old who has opioid dependence and nicotine dependence. She has a 2-year-old baby. She wants to quit heroin and willing for admission. So in cases of female patient who has a child less than 3 years of a woman receiving care, treatment or rehabilitation at a Mhca shall ordinarily not be separated from here, if separated by MHP, decision should be reviewed every 15 days by mental health professional. If more than 30 days, then shall require approval by the respective authority in cases of female patients with a baby. So this was all cases. If a patient who was prisoner and admitted in our institute and absconded without any information, then we will apply this form and we will send to the station in charge of nearby police station. And this was the SMHA notice of the UP state. In as per this, in 75 districts there is MHRP, and total 6 members are there in MHRP. One should be district magistrate, second will be representative of district collector, and one will be psychiatrist, medical practitioner, and 2 members who shall be person with mental illness or caregiver, or persons representing organizations of person with mental illness or caregivers or NGOs. Total 6 members should be there in MHRP. So this is the summary of all the forms.
Thank you very much. So